Yes, it's a post-op actually. It's a 8 months follow-up. It looks like now the bone is there. It looks like the bone is there. Another actually case, the resorbed mandible. The more the mandible, the more the maxilla you are getting resorbed, you can complete faster actually. When the good bone case is there, you are going to take 2 to 2 hours. If the resorbed mandible is there, resorbed maxilla is there, you can complete the full mouth in a 1 hour. Again, buccal bypass. This case was done in the course and we were so lucky, Professor Lucas sir was also there along with us. Flapless, neat and clean case. Another case, this case was given by our KGMC Lucknow by Dr. Lakshar. This patient was having ectodermal dysplasia. Operated, completed the case. The mandible was really thin, only the bone was available at the base. Buccal bypass, completed the case. Now, these were the routine cases were there, okay. You do, again you started getting bored. So what you have to do, you have to search for the resection cases. These are the cases that are going to make you actually your day, okay. Otherwise, these type of cases you are doing, you are always looking actually after doing the case in the evening only beer, but you have to deserve a vodka, okay. So I will coming to the cases. This is a cleft lip, cleft palate patient was there. This is a cleft, okay, it's a healed cleft lip, cleft palate, okay. This is simple cases there. We just placed the implant. At that time, I didn't know how to place the double pterygoid. We were placing the double pterygoid. We didn't know what was double pterygoid at that time. Okay. So 2 implants at the nasomaxillary buttresses region, and 1 implant at the pterygomaxillary buttress, and 1 implant at the pterygoid region. He is using a silicone material actually as an obturator. These are fixed processes. Post-op and the follow-up. We are having a 3-year follow-up of this patient. Now come the real cases. This case, good. We are not having any competition. When we are presenting these cases, we are always having a good friendship with all our conventional guys. Because we say, whatever the cases you are rejecting, please give it to us. Okay. That's all. We are going to help the community. This is the case. Malignant melanoma, resected. So what we were available actually, what the bone was available at that time for us. We had the nasal cortical, we had the nasomax buttresses available, and we have the zygoma was available. In zygoma, when we are placing the implant, there is no need of place of 2 or 3 zygomas. If you are placing a 1 zygoma properly at the jugal region means at the posterior aspect of the zygoma and the anterior aspect of the zygomatic arc. That's a highly mineralized bone is there. So one implant can also do it, but you can place 2 or 3 implants, whatever you like. So at that time I started using the Stella Werner technique. You know why? You just have to see, you have to reflect it, make a slot and place the implant. So this, I used my piezotome. My piezotome was there from the conventional days. You know, I just dusted my piezotome, brought the piezotome and operated. I made a slot and placed the implant. Zygoma, nasomaxillary buttress engagement, and the 2 implants. It was also a fairly easy case, because now we have started. Easy case means when we are doing right now, what are the cases, the future cases we are doing, or the cases we are looking at. So whatever the case we have done earlier, say, come on, you were jumping out that time, oh, come on, you have done something good. But these cases were so simple actually. Let's move forward. Impression. No swelling actually, or you can say minimum swelling. Completed the case. When we put a zygoma implant, actually we are expanding the supporting polygon. We create a tripod. Now, okay, another good case I got. It is against the maxilla. The resection has been done. So what I have done, I placed the zygoma implant. This zygoma was a bit tough actually because I have to take out a lots of bone. But what zygoma technique I am using? I am using a Zaga technique, anatomy guided zygomatic approach. Reflect the flap, check it. Always first of all you have to put your finger at the infraorbital foramen. This you have to save. Then place your finger at the jugal region. Do the osteotomy, perforate the cortical, and just engage the implant. You can see all the oral surgeon you can appreciate. After this bone, there is no bone is available. So this is the nasomaxillary buttress. I just place the implant just vertically, engage the nasomaxillary buttress region, and then I banded the implant. If you can bend the implant, that means really you are in a good bone.